Well, good morning. My name is Chris Fanta, and it's my great pleasure to welcome you to Partners Asthma Center's Asthma Grand Rounds this morning with a very special guest speaker, Dr. Michelle Cloutier. And before I introduce Dr. Cloutier, I just want to go through our usual administrative housekeeping to indicate that we'd welcome your questions that we will share with Dr. Cloutier at the end of her presentation. You can submit these questions now because we're all on Zoom via the chat feature of the Zoom application, or you can text them to 617-513-6043. And if you'd like CME credit for participating this morning, simply send me your name, title, and email address to cfanta@partners.org, and I will forward them to Harvard Medical School, and you'll be sent an evaluation that then gets you CME credit. And were there any technical difficulties, and I hope that you won't have any, you can get a rapid help by sending an email to BWH Webcast Troubleshooting at partners.org. So it is a great pleasure to introduce our speaker this morning. Dr. Cloutier is a pediatric pulmonologist. She's professor of pediatrics and medicine at the University of Connecticut School of Medicine. She's founding director of the Asthma Center at the Connecticut Children's Medical Center, and her work in asthma research in Hartford really transformed the care of children with asthma in the city of Hartford and sent a model that is available to use worldwide in improving asthma care in children. And as you know, she was selected then to be the chair of the expert panel working group for the National Asthma Education and Prevention Program, charged with revamping and updating the set of guidelines for asthma management. And I think those of you who have looked at those guidelines will agree that she brought together a group that did so with incredible integrity and scientific rigor. And so it's a great pleasure to introduce Dr. Michelle Cloutier, who's going to speak on the new asthma guidelines from the National Asthma Education and Prevention Program.
Well, thank you so much for this invitation to speak. I'm just going to try and get, there we go. All right. So hopefully you can see my slides and hopefully you can hear me. And if you cannot, if you would let Chris know, he can let me know. But thank you so much for this opportunity. It's been a busy couple of months for the guidelines, and I'm really excited to talk to you and to hear your thoughts and comments about the guidelines. So what my goal is this morning is I'm going to spend, and I'll tell you, I did this in consultation with Chris to sort of think about, well, what do people want to hear about? And I'm going to spend a little bit of time reviewing the methodology that was used, because I am both proud of that methodology, but it is also an extraordinarily rigorous methodology. And hopefully it has resulted in guidelines that everyone will trust. I want to briefly discuss the new recommendations. I'm going to go into greater depth in a couple of the recommendations, some based on really work from your community about things that I think you might be interested in. And then I'm going to speculate about where to go from here. So here's the timeline for the guideline itself. So a needs assessment was conducted back in 2014. And as a result of this national needs assessment, 6 topics were chosen for updating. And key questions were identified by the National Heart, Lung, and Blood Advisory Council for updated in a revision. Subcontracts were then signed with AHRQ to address these key questions using P codes, and protocols were established and the systematic reviews were published. In July of 2018, the NAEPP Coordinating Committee, of which Elliot Israel is a member, convened an expert panel working group to use these systematic reviews to develop guidelines. The first thing that the expert panel did was to conduct a literature search, to update the literature search through October of 2018. So the recommendations are through 2018. A draft document was then made. It was released to the public for public comment. And in December of 2020, the guideline was published in the Journal of Allergy and Clinical Immunology. So by way of an overview, the 2020 Focused Asthma Updates is a focused update of 6 priority topics. It is not a revision of EPR3. It used grade methodology to assess certainty of evidence and strength of recommendations. We limited the use of expert opinion, and we also tried very hard not to extrapolate data across populations or age ranges. This did result, I think, in some funkiness to the recommendations that I'll talk about, but there was a clear reason for doing that. We did address the pre-specified key questions using the best available evidence from the literature through October of 2018. We also used extensive conflict of interest policies. Individuals who had apparent COIs were recused. Those who had definite COIs actually stepped down from the panel. And for the first time, the NAEPP has included an implementation guidance section that we hope will facilitate use of the recommendations by primary care clinicians. Here are the members of the expert panel. They represented asthma content experts, so allergists, pulmonologists, pediatric as well as adult, primary care, so pediatrics, family medicine, internal medicine, emergency medicine. They represented healthcare policy people, as well as dissemination and implementation experts. And they did an absolutely awesome job as volunteers. And as you can imagine, this is a great deal of work. So what were the topics that were chosen? I think you all probably know those topics: pheno, indoor allergens, intermittent inhaled corticosteroids, the use of LAMAs and where it fits, immunotherapy, and bronchial thermoplasty. And 3 of these 6 are new to the guidelines. So bronchial thermoplasty, the LAMAs, and pheno are new to the guidelines. They have not been in previous iterations. There were other topics that were considered as part of that needs assessment, and those other topics are listed here. And there is one that sticks out. I purposely highlighted it to make it stick out, and that is the biologics. In 2014, 2015, when this national needs assessment was being conducted, there was only one biologic on the market. That had been released in 2003. And the advisory council felt that the biologics represented an emerging topic, but had not sort of reached a level at which it should be included in the update. And clearly this was a mistake, but again, hindsight is 2020, and we had no crystal ball. There was no crystal ball for this. So what about the implementation guidance section? Well, An implementation guidance section follows each recommendation, and and they all look the same. That is to say, it starts off with a clinician summary of the recommendation. So it provides a little more, in a little more narrative form, less formal form, a few more details about the recommendation. It's kind of like the Cliff Notes of the update. That's then followed by tips for using the recommendation. And it's what I call the who, what, where, and when. So who to use it in, who not to use this recommendation for, what is the recommendation, examples, if it's a pharmacotherapy, examples of treatments that were actually used in the various studies, the setting, and when to use them. And then the final section is a section on how to discuss this recommendation with patients. This is purely the expert panel's suggestion, and it really talks about and stresses the importance of shared decision-making in deciding whether a course of action is appropriate for a particular individual. And it talks about what are the potential patient-centered benefits of this particular intervention. So for example, there are interventions that improve asthma control and quality of life, but have no benefit when it comes to exacerbations. And so if exacerbations are important for your particular patient, then this might not be the best course of action for them. It then talks about what are the risks to the individual and what other options might be available and of use. So it's meant to really help clinicians in talking to patients about whether to begin an intervention or a course of action or not. So I want to just spend a couple minutes talking about GRADE. I think it's still new to some people. So GRADE stands for Grading of Recommendations, Assessment, Development, and Evaluation. And it is an internationally accepted approach to determining quality or certainty of evidence and the direction and strength of a recommendation. It's used to review the evidence and to develop evidence to decision tables. And then finally, to use those evidence to decision tables to develop recommendations. And there are three sort of main elements or components to GRADE. The first are the creation of what are called summary evidence profile tables. And these are summaries of the outcome measures for the course of action for each critical and important outcome. And I'll talk about that in a minute. This is then incorporated into the development of an evidence to decision table. And it's a very systematic, transparent way to examine each individual component of an outcome or of a course of action. Now, you may not agree, and I doubt that you agree with all of the recommendations in the update. However, you can see exactly how that recommendation was made, how the benefits, how things were weighted in the course of making that recommendation. And the final element is obviously the crafting of the recommendation. So the first thing that we had to do was to determine important outcomes. And critical outcomes are outcomes that are felt to be essential to saying that an intervention is effective. And we came up with 3 critical outcomes, and all studies were examined for these critical outcomes. They included exacerbations, which were defined in a variety of ways. It included asthma control, and it included asthma-related quality of life. Again, these are patient-centered outcomes. There were other outcomes, however, that were deemed important. And for some of the courses of action, important outcomes were considered critical. And this included asthma symptoms, which you'll see is a critical outcome for allergen mitigation strategies. And then there were ones that were very topic specific, particularly for something like bronchial thermoplasty. We used validated instruments and instruments with minimally important differences whenever they were available. Then the evidence profiles for each critical and important outcome were developed. And you begin with a randomized control trial, which you begin with high certainty. You say a randomized control trial has high certainty. And then it gets marked down for various concerns. For example, risk of bias. So if it was not blinded, for example, it gets marked down for imprecision. So if it has wide confidence intervals or boundaries that demonstrate both benefit as well as harm, or if the results are inconsistent. Some studies are positive, some studies are negative. All of these things decrease the certainty of evidence. For each outcome, the outcome is assessed to be of high certainty, moderate, low, and very low certainty. And we've demonstrated, and we've sort of defined those certainties of evidence here. Yes, we think this really is true, and we don't have very much confidence in this outcome. So then, once you have these evidence profiles, you make a series of judgments. And each judgment you have to decide upon before you move to the next one. And we look at not just the statistical significance of an outcome, but we look at the magnitude of the outcome. We look at the net balance of harms and benefits. And this is one of the major differences between GRADE and other sorts of platforms, in that harms are considered a part of the recommendation and influence the recommendation. And so do patient preferences, the certainty of evidence from the evidence profiles, the issue of equity, the issue of acceptability, and the issue of feasibility. It may be the greatest thing since sliced bread, but if it's not feasible, then it's not going to be highly recommended because you just can't do it. We then developed the recommendation, and then there was a formal voting where each recommendation was formally voted upon by the working group members, and that is those who did not have apparent COIs. And consensus was achieved for each recommendation, and consensus was defined by the expert panel as 90% agreement with the recommendation. And then the last step, which is again not unique to the NAEPP, but unique to many guidelines, is that the recommendations were modified based upon a lot of public comment and input. So here's an example of an evidence profile. I'm actually going to show some evidence profiles as we move along. So I just want to spend a minute here so that we don't have to spend a lot of time when we see them moving forward. So here is a critical outcome. It is exacerbations. In this instance, it was defined as requiring systemic corticosteroids. And this, by the way, is intermittent inhaled corticosteroid with as-needed SABA compared with SABA alone in ages 0 to 4. It then makes some comment about how long the follow-up period was. The number of participants and the number of studies. So you see the total number of participants, you see the total number of randomized controlled trials. They are referenced at the end of every evidence profile so that you can see which studies entered this. The certainty of evidence was considered high here. So they must have been blinded studies, they had good precision, and they were consistent. And the relative effect, when we're able to calculate that, is shown here. This represented a 33% decrease in the number of courses of systemic corticosteroids per year. Then there's, if there's additional sort of risk assessment that we can include based upon the evidence provided in the studies, we put that here. And then we make a determination that for exacerbations, and this particular one requiring systemic corticosteroids, the results favor the intervention. And we do this for every exacerbation, every critical outcome and every important outcome. The final recommendations were then vetted. And I think this is an amazing vetting process. So there were 19 expert panel members who obviously vetted the recommendations. There were 15 NAEPP coordinating committee members representing various professional lay organizations, some nonprofits, a whole variety of federal groups who also vetted the recommendations. There were 11 interviews. These were in-depth interviews with board-certified healthcare clinicians to understand their perspectives. Experts from about 10 federal agencies were involved. We received more than 500 comments from members of the public, including individuals, society. So wide individuals and groups commenting. And we went through every one of these comments and recommendations and incorporated many of the suggestions into the final document. In addition, and this is thanks to sort of Elliot helping us to get this through the group, we conducted a range of focus groups that were very targeted. They included adults with asthma and caregivers, but they were very specific for the recommendations of what you thought about that, how you feel about this sort of intervention, what are the issues that you see. So it was a very focused focus group series. So the direction, this is the last of these, the direction and strength of the recommendation. There are 4 types of recommendations that are possible. You could have a recommendation for or against an intervention. And within for or against a recommendation, the recommendation could be strong or conditional. And there are many levels of strong and conditional recommendations. So for patients, a strong recommendation is a recommendation that almost all people with asthma will want this intervention. For clinicians, almost all patients should receive the intervention. For policymakers, and this is important specifically when we talk about smart therapy, the recommendation can be it should be adopted as policy or a performance measure. And that's very important to some of the things we hope to achieve. And then for researchers, it's supported by credible evidence. But if it has low certainty or very low, new research could be very useful in that area. Conditional recommendations, on the other hand, most would want, but many would not. Different choices will be appropriate for different individuals. This is where shared decision-making is particularly important. And then for policymakers and for researchers, more work clearly needs to be done. So on to the recommendations. And I decided to start with the effectiveness of indoor allergen mitigation strategies, in large measure because a lot of work has been done, is being done in your community, in your broader community, in your state, in this area. And I wanted to sort of spend a few minutes talking about this. So I've summarized the recommendations here. And what is recommended in the update are multi-component allergen-specific mitigation interventions. And the only really allergen-specific mitigation strategy that's recommended as a single, all by itself, a standalone, is integrated pest management. Impermeable pillow and mattress covers, dust mite impermeable pillow and mattress covers are recommended not as a single intervention, to stand alone. They are not effective. But they can be used as part of a multi-component mitigation strategy. But all of these are recommended only for individuals who have a history of exposure to that specific allergen and either have evidence of sensitization by skin testing or by allergen-specific IgE, or have symptoms upon exposure. Recommended against are mitigation strategies in individuals who have no evidence of sensitization or symptoms related to exposure or no history of exposure. That is to say, allergen mitigation strategies, interventions, are not recommended as part of routine asthma care. What are some of the considerations for allergen mitigation? And then I'll show you a little bit about where the specific recommendations came from. Well, the first is that in keeping with the recommendation in EPR3, and by the way, if it wasn't, if something was not specifically one of the key questions in for the update, recommendations from EPR3 were pulled through. They were not changed, they were not altered, they were simply pulled through. And this is one of the pull throughs. That is to say, the recommendation that every individual with asthma should be assessed for exposures. The strategies that one uses in mitigation can be used in individuals with asthma of all ages and all severities. So there are no specific criteria there. Again, the strong statement is that is the recommendation to implement mitigation strategies only in individuals with a history of exposure and either sensitization or symptoms. And when implemented, implement multi-component mitigation strategies targeted to the offending allergens, and single strategies are not effective. Which specific combination of strategies are most effective cannot be determined from the data. There was a wide range of what people looked at. The rationale for some of the interventions was not clear. There were instances, and in one in particular, of probably the best study of all of the allergen mitigation strategies was one of integrated pest management, in which, for reasons that weren't clear, dust mite, impermeable pillow and mattress covers were included in the intervention. And that actually made it more difficult to assess sort of what was driving the outcomes. For all of the allergen mitigation strategies, the benefits were small, but so were the harms. And that's why there were conditional recommendations for some of these interventions. There was a concern, and this is now an opinion expressed by the expert opinion, by the panel in the implementation guidance section, a concern that stressing these interventions could distract from other aspects of therapy and may be associated with a patient burden and ongoing costs. These are now beyond the research studies. And I will also say that public health considerations did sway the committee on several occasions, particularly for pest and for mold, in terms of making the conditional recommendation, even when the data were not especially strong. So here is sort of a summary of the evidence to decision results for different of the interventions. So we can see that for many single component intervention strategies, there was insufficient evidence that's marked by the dagger. There's insufficient evidence to assess the effectiveness of single component interventions. Most of the time interventions were combined into multi-component ones, but there was clear moderate certainty of evidence, clear data that impermeable pillow and mattress covers as a single component make no difference in any of the critical or important outcomes. Integrated pest management now, we considered that a single component intervention, although we recognize that it's really multi-component, but it's sort of a package deal is how we looked at it. And air filtration systems and air purifiers as single interventions, again, it was low certainty of evidence, but there was no evidence that supported that it was effective. And I think this is a table from the guideline, and I encourage you to sort of look at that specifically. But I'm going to look at the evidence to decision tables for two of these because I think they might help in sort of understanding how the expert panel worked as well as the recommendation. So this is an evidence to decision table for integrated pest management with other interventions. So this is multi-component versus placebo or no pest management intervention at all. And it is for exacerbations, for asthma control, quality of life, and asthma symptoms, which again, for allergen mitigation strategies was considered a critical outcome. And we see that if you look over on the right-hand side, that a composite measure, there was improvement. The result was that while we were unable to calculate our relative effect size because the data were just not presented in a way that we could do this, but the data were felt to favor the intervention. But there was no difference for other measures of exacerbation. The asthma control test, again, we stressed validated measures were inconclusive. The quality of life measure, moderate certainty in favored the intervention, as did asthma symptoms, again, defined in a whole variety of ways with non-validated measures. But the overall impression from this evidence to decision profile, from this evidence profile, is that integrated pest management was beneficial as compared to placebo. When we look, however, at the multi-component interventions that included air filtration systems and air purifiers versus no intervention, there was no difference in terms of hospitalizations. And this was 4 randomized controlled trials, 1,600 participants. There was no difference in the asthma control tests, or asthma control. There was no difference in quality of life. The asthma symptoms did, we thought, favor the intervention. There were some problems with imprecision and inconsistency, particularly in that there were some reduction in symptoms in 2 randomized control trials in children, but no difference in 2 randomized control trials in mixed population participants. So this is both adults and kids. And the overall feeling was that this was this did not favor the use of air filtration systems or air purifiers. And 3 of these 4 studies were HEPA systems. Moving on now to intermittent ICS. A short course of daily inhaled corticosteroids is recommended for children 0 to 4 years of age with a history of recurrent wheezing triggered by respiratory tract infections only, and no wheezing between infections, recommended at the onset of a respiratory tract infection with SABA then as quick relief. So a 7 to 10 day course of ICS SABA in children 0 to 4 who have had 3 or more wheezing episodes with respiratory tract infections and no wheezing in between. This is step 1 therapy. The second is the use of either daily low dose inhaled corticosteroids and as needed SABA for quick relief, or this is, so that's what's recommended in EPR3 currently, or as needed, so intermittent ICS and SABA used at the same time, usually the SABA followed by the ICS, in individuals 12 years and older and adults who have mild persistent asthma. This is the recommendation for step 2 therapy. And there is a recommendation against a short-term increase in ICS dose for increased symptoms for individuals 4 years and older, mild to moderate persistent asthma, who are likely to be adherent to daily ICS treatment. So that's a mouthful. I'm going to talk a little more about that in a minute. So what are the considerations here? Well, for step 2 therapy, the benefits of daily versus intermittent ICS were similar. And the risk of harms was small. And so the recommendation really, in implementing this recommendation, there's a strong statement for using patient preference in deciding which of these 2 therapies to use. I want to say one more comment about patient preference. And some of this came as a surprise to us. I think if you ask people about, would you prefer daily or intermittent ICS? I think most clinicians would say, well, my patients would prefer, because they don't use daily, they would prefer intermittent ICS. In patient focus groups, now these are patients who are not involved in any clinical trial. So it's not like they've tried a therapy, have found success with it, and of course they want to stay on that therapy. But rather, these are patients who really don't, may or may not be on a regular. While there are many who said, oh, I prefer intermittent therapy, there were also many who said, I prefer daily therapy. And the rationale for this is twofold. One is that I can take my medicine every day and I don't have to worry about this. I'm well. I feel great. I don't have any problems. I don't have to worry about this medication. And for caregivers, the second issue was I don't have to worry about when they're at somebody else's house and they have a problem. How does that individual make a decision for a child about the use of intermittent therapy? And so it made life simpler for some individuals, and it made it more likely to be used for other individuals. So I think this is why there's such a stress on shared decision making. However, daily versus intermittent ICS, ICS exposure will vary. And for children, there may be growth effects. And so that has to be a consideration and has to be monitored. Not examined in step 2 were other combination therapies such as ICS and formoterol. This was not one of the key questions. The systematic review was not done, and therefore it was not addressed. The other sort of point to stress is that in individuals whose asthma is well controlled on their current therapy, the expert panel does not suggest changing that therapy. If it's working well, don't change it. Leave them on that therapy. So use the therapy that's really best for that patient. And then the recommendation against the doubling, tripling, quadrupling, quintupling is really for individuals who you think are reasonably compliant with your therapy. So they have reasonable adherence to that therapy. Now, how you define that, what the limits are, was not addressed or dealt with. So that quintupling the ICS dose in adolescents and adults during an exacerbation may be beneficial in individuals who are not adherent to therapy. And again, that's part of that shared decision-making and care. So here are the results for step 2 for intermittent inhaled corticosteroids versus a daily inhaled corticosteroid, both with SABA rescue. And as you see, looking down for exacerbations defined in multiple ways, there was no difference. There was no difference in asthma control, no difference in quality of life, and no difference in rescue medication use between intermittent therapy or daily therapy, both using, with both of those approaches, using SABA as rescue. Moving on now to SMART therapy, and we do prefer to call it SMART because it very specifically defines the limits of what this therapy is. And it also stresses the fact that it's a single maintenance therapy and reliever therapy. It is what is recommended is the use of ICS formoterol specifically in a single inhaler as both daily controller and quick relief therapy for children 4 years and older and adults with moderate up to severe persistent asthma. This is one of only 3 strong recommendations in the guidelines. There's high certainty of evidence for 12 years and up and moderate certainty of evidence for 4 to 11-year-olds. So the implementation considerations are sort of discussed here. In step 3, so SMART is recommended as the preferred therapy for step 3 and 4. In step 3, the preferred therapy is 1 to 2 puffs, 1 to 2 times per day daily, and then an as needed using a combination low-dose ICS formoterol, up to 8 puffs per day for children and 12 for adolescents and adults. And in step 4, it is a medium dose of ICS formoterol used both daily and as needed. Why specifically formoterol? Because of its rapid onset of action. Here in the US, it is the only one of the rapid onset of actions, and it can be used more than twice a day. ICS formoterol is FDA approved for use in children 4 years and older. So that's one barrier, one less barrier that we have to that therapy. Again, for individuals with moderate persistent asthma, if their asthma is well controlled on alternative therapy, do not switch to SMART. And that is a suggestion throughout all of the recommendations. There are, however, challenges, and there are some unanswered questions relative to this. The first for us here in the US is the prescribing of more than one inhaler per month, and that is problematic because clearly patients need more than one. At last week's Quad AI, both Elliot and I sort of suggested some ways that people might be able to get around this. One is when writing a prescription, prescribe one for daily use and one for rescue use. And if your insurance company doesn't have really strict requirements in that area, the patient will get 2 of them. Some people have used, and I didn't mention this last week, and some people have used a higher dose of the ICS. So in step 3, they might prescribe the medium dose of the ICS, but use fewer daily puffs and sort of try and kind of get around that. I don't recommend that. I think that's very confusing for patients. Remember the policy implications of this strong recommendation. And I think there's effort going on right now to use SMART therapy as a quality measure. There's sort of this hope that we're going to be able to push that through, as well as working through the pharmaceutical industry to get this approved as a new use and therefore get coverage for it. I do believe that there are some concerns about using a SMART therapy as part of exercise pretreatment. And I may hopefully get to talk a little bit about more about that toward the end. So I want to move on to immunotherapy. So immunotherapy, subcutaneous immunotherapy is recommended as an adjunct to standard pharmacotherapy in individuals 5 years and older with mild to moderate allergic asthma. And it's recommended against is sublingual immunotherapy. And the reason for that are shown here. SCIT, or subcutaneous immunotherapy, the benefits of SCIT include small improvements in symptoms and quality of life, and a potential reduction in long-term medications. And it may, and I think this is an important aspect, may improve comorbid allergic conditions. There is, however, a risk of systemic reactions. And so in using SCIT, some of the tips to using it are to, one, optimize control both at the start as well as during the course of treatment, avoid the use in severe asthma. And the reason for that is there are greater risk of systemic reactions in individuals who have severe asthma, particularly severe asthma that's not controlled. Administer SCIT in clinical settings that are prepared to treat systemic reactions, including anaphylaxis, and do not administer at home. The rationale between sublingual immunotherapy was there are, first of all, a limited number of SLIT allergens that have FDA approval, and that's FDA approval only for allergic rhinoconjunctivitis. However, there may be some benefit of SLIT, particularly in individuals who, again, have allergic disease as part or as a component or in addition to their asthma. So again, it's a shared decision-making. We're almost done. I want to talk about use of pheno. Pheno as an adjunct in asthma diagnosis. So in other things, it's not clear what the diagnosis is. Pheno is useful. And it's also useful in asthma monitoring when there's uncertainty about what to do. It's recommended against, and these are the other two strong recommendations in the update. Recommended against use in isolation for asthma control, to predict exacerbations, to assess exacerbation severity, or to predict the future development of asthma. Now, pheno is easily performed by most individuals. It has no significant adverse effects, but there is an expense to the equipment and ongoing supplies. May not make this cost-effective for use in primary care offices, and referral to a specialist may be necessary. Results can also be difficult to interpret, as there are many things that both increase and decrease pheno levels. It really should not be used to assess adherence to treatment, whether somebody is using their ICS or not. LAMAs are recommended for the first time in step 5 therapy as part of triple therapy in step 5. And the next two recommendations place LAMA in terms of LABA therapy. And I think they're easier to understand here. So ICS LABA is preferred compared to ICS LAMA, even though the studies show similar benefits. And the reason for this is there is a concern related to the harms for ICS LAMA therapy in African Americans from the BELT study, in which the LAMA arm had more hospitalizations and 2 deaths. When, however, ICS LABA cannot be used, then LAMA is an alternative. ICS LAMA is an alternative approach. Tiotropium and recently umeclidinium have been FDA approved. LAMA is now approved for ages 6 to 12. It was not a key question, and so studies were not addressed. Individuals at risk for urinary retention and with glaucoma should receive this therapy, and it does require a different inhaler. So here's sort of the final pharmacologic updated step diagram for, excuse me, 12 years and older. And I've bolded those recommendations that are new. And you can see for steps 2, 3, 4, and 5, there are new preferred recommendations for therapy. And finally, there's a recommendation against bronchial thermoplasty. Small benefits, moderate risks, but there is a caveat. And there are going to be patients who will want this therapy because the risk of harm, so short-term worsening of symptoms, unknown long-term benefits, are not as important as the potential benefits of improvement in quality of life and a small reduction in exacerbations. We do suggest, however, that if you're going to perform bronchial thermoplasty, to do it in the context of registries. So as a kind of coming to the end of this, I am asked quite frequently about comparing the 2020 asthma update in GINA. And I think there are some fundamental differences in the documents themselves that make it unfair to actually compare them. And I want to urge caution in doing that. We did not do this in the guidelines because we were not there to compare the recommendations to other guidelines. And the first and foremost is the purpose of the document. The 2020 asthma update is a guideline. GINA is not, and GINA specifically, and Helen says this every time she speaks about it, it is a global strategy document. It's meant to be for use in a global environment. The processes used were very different between the update and GINA. We used grade, systematic reviews were conducted by outside groups, had strict conflict of interest management policies. There were 13 years between the guidelines, which is so unacceptable. And the strength of GINA is that it is updated yearly. The NAEPP uses PICOs and a priori key questions. GINA is more of an opportunistic. They look at they do an 18-month look back at the literature and then pick the things that they want to update. One of the big differences and what makes it so hard to compare is that the step diagram in the update is 6 steps that are linked to asthma severity. There are 5 steps in GINA, and there's actually a lot of disagreement about whether there's been a combination of steps 5 and 6 or 1 and 2, because there's a real blurring in steps 1 and 2, which makes it hard to compare. We did not extrapolate data between steps, and then the recommendations themselves. And I think it's important to note that the preferred steps 3 and 4 is ICS-LABA in GINA, with ICS for Moderall rescue. And that's part of why they call it MART and not SMART. And part of why the NAEPP calls it SMART, because it is that specific therapy. Finally, what are some of the challenges? Well, the first, we need to re-examine the definitions of asthma severity. This is, are these current definitions, are they still appropriate? What do they mean? How can we better clarify them? We have to define what's low, medium, and high dose ICS. That needs to be looked at. We need to establish and standardize subpopulations of asthma, whether that's by severity or allergen specific sensitization or airway inflammatory phenotype or endotypes. We need to standardize reporting of results. They were not, you can't just say, 40% were Hispanics. We really need to see the Hispanic data as a separate data, separately. The results. And we really want to encourage that if we're going to be able to drill down at that level. There were also a lot of problems with the outcome measures. Often minimally important differences were either not available or they were not used. And that makes it very difficult to extrapolate evidence profiles. Clinical relevance also needs to be established, and there needs to be more stakeholder input into that. And I hope some PCORI work is going to help do that. Also missing is, even though the key question said that this was what is the comparative effectiveness, the studies were all except for one, they were efficacy trials. Preferences of individuals with asthma, specifically in the study, need to be included. And we need to look at how they might vary depending upon race, ethnicity, asthma severity, age, socioeconomic status. We need cost effectiveness studies, and safety data needs to be explicitly included in publications of clinical trials. To say no one died, no one died, and that's important, is the sole sort of indication of serious adverse events is not sufficient. Future directions, obviously, we need the biologic agents need to be included. Again, there was a paucity of evidence based on standardized outcome measures. Most did not use validated outcome measures. And I encourage people to look at the 2012 Asthma Outcome Workshop report. And the question is whether that needs updating. We need a better system for updating asthma guidelines. Characteristics of that system, they need to be timely and efficient. 13 years is unacceptable. They need to be ongoing and in real time. They need to reflect the current state of evidence. They need to be sustainable. We can't keep having an expert panel group and then it goes away and then something gets reconfigured, et cetera. Whatever we do, it has to be transparent. You've got to be able to understand how the recommendations were developed. It's got to be rigorous. It's got to use the state-of-the-art methodology. We can't be using old school stuff. We've got to have strict conflicts of interest policy, and we've got to manage it. It isn't enough just to list what your conflicts are. How were they actually managed? And it has to be patient-centered. So why is this update usable and trustworthy? Because it addressed pre-specified questions, it used the best evidence, it used grade methodology, it limited expert opinion, was highly vetted, and hopefully the implementation guidance. I want to thank members of the panel. I want to thank Jim Kiley and George Benza, as well as the NHLBI and Citrus staff, the coordinating committee members who were fabulous, and everyone who took the time to read and comment upon the draft itself. And I'm happy to answer questions. I went 5 minutes longer than I wanted to, but I'm happy to answer any questions. So I'm going to now stop sharing my. Over to you, Chris.
Done presentation, and thank you for your work that I think we can all who practice asthma care can be very proud of the document that you created and are disseminating. So we'll open it up for questions. I think I get to ask the first, which I wanted to ask about outcomes that you chose for the various questions that were being asked. And I was struck by the absence of lung function or measurements, you know, like FEV1. And what was the thinking behind excluding that as an outcome measure?
Yeah, it's a great question. I'm sort of known to, there was a very strict process by which we chose the outcome measures. And there was, the top three were the critical ones, and then 4, 5, and 6. And then there was a big gap, and lung function was down in that gap. Some of it had to do with the fact that pediatric studies would get excluded or not included. Others were that lung function was not considered a patient-centered outcome measure. Patients don't necessarily say, well, I have an FEV1 of, 85% are predicted. And so what GRADE uses is GRADE stresses patient-centered outcomes, and lung function was not included in that. That's the short answer.
Gotcha. Quick questions were submitted about the role of a single inhaler for maintenance and rescue therapy. Can that be brought into the schools as opposed to an albuterol inhaler used in a school setting?
Oh, in schools, well, we've not even sort of addressed that. But clearly, if smart therapy is as needed therapy, we're going to have to use it in the schools. And I actually don't see this as a major issue for use in the schools, except for the fact that we need that additional inhaler. And so when we think about it as a measure, as a quality measure, we need to consider where all these inhalers need to be.
In a similar vein, a question came up about the use of the ICS-LABA combination with formoterol prior to exercise. Is it a safe, a good substitute for albuterol?
Yeah, so the studies of smart therapy in particular, well, let me step back. So we know that long-acting bronchodilators can be used for exercise-induced asthma. We knew all of this back from the salmeterol, Ceravent days when it was a single inhaler, and lots of individuals, particularly athletes or people who consider a 50-mile bike ride a walk in the park, use the LABA. So we know that LABAs can be used. What is unclear is how exercise pretreatment fits within SMART itself. Will it do harm? I don't think it will do harm. But is it extra or excess medication? Yeah, I think there's a possibility that it's unnecessary. And that is particularly true, and I'm going to step outside my role, particularly true when we think about GINA, and GINA about recommending ICS formoterol at really all levels of severity. That's a lot of ICS formoterol, and the question is whether all of that, if that's an excess amount. And so I think we need to look very carefully at it. For individuals who exercise every day, that's an additional 2 puffs of ICS. So one of the advantages of SMART is a reduced ICS exposure. Well, we minimize some of that when we're using it for exercise. So those are the considerations. I don't know that I have answers about whether we should use that or not. I think it's safe.
Maybe we could take advantage of you and ask one last question, if we might. The question had to do with the fact that many of the published studies about SMART therapy use the dry powder inhaler device.
Yeah.
And the question has come up about the equivalence of the meter dose inhaler, or just general recommendations about medication delivery by dry powder versus meter dose inhaler with spacer that apparently wasn't addressed in the guidelines.
Yeah, it wasn't addressed because it wasn't one of the key questions. And I don't know that there's a whole lot more information now than was available in 2007, except for the fact that we've got all these new sorts of devices. I personally would look at it as, and again, I have to say I'm a former pediatrician pulmonologist because I am retired. But I look at it in terms of the child and how competent the child is to do this. So when I see 8-year-olds who, do this with, a dry powder inhaler, this is the problem, right? And breathe into it, and I'm not going to use a dry powder inhaler for them. So again, I like them both. I like them both, but I tailored it, I think, to this specific patient. Sorry, it's a cop-out, but.
I think it was a fabulous presentation. Thank you so much, Dr. Cloutier. This is a model, not only of science, but it seems to me of retirement. Thank you all.
Well, I'll tell you, it's a great gig. Retirement's a great gig. I recommend it highly.
Thank you all for participating, and we look forward to you joining us again for our next program in June. Take good care.